An article published this week in AJR looked at architectural distortions detected only on digital breast tomosynthesis with no ultrasound correlate and that were not malignant on core biopsy. The authors used a standardized approach of recommending excision for distortions with atypia versus recommending 12 months of diagnostic imaging follow-up before returning to annual screening for those without atypia. At 1 year follow-up, the malignancy rate was 0% for distortions without versus 20% for those with atypia, supporting the safety of the non-surgical approach for select cases. I'm Andy Rosenkrantz, editor-in-chief of AJR, and I'm here today to discuss the article with its lead author, Dr. Derek Nguyen, assistant professor of radiology at Duke University. Dr. Nguyen, thanks so much for joining us.
Thank you so much for having me. It's a pleasure to be here.
To start us off, can you tell us about your breast imaging practice?
We are an academic institution with 14 breast radiologists across 2 outpatient imaging sites.
Now, how did you and your team come up with the management strategy that you describe in the article?
Great question. So our approach stemmed from a journal club discussion back in 2020, where we reviewed the study by Binder et al., looking at biopsy outcomes of architectural distortions without a sonographic correlate. That discussion led to a multidisciplinary meeting between our breast radiologist, breast surgeons, and breast pathologists, with the goal of trying to reduce unnecessary surgical excisions for benign distortions. As a result, we developed the standardized protocol for workup of distortions, biopsy of distortions, and management of distortions, as we detailed in our manuscript.
You also talk about the importance of the biopsy technique. Can you tell us more about this?
Absolutely. So since 2020, when we implemented our standard protocol, whenever we biopsy a distortion, we will always target at the center of the distortion from the tomosynthesis scout images, and we obtain 12 vacuum-assisted 9-gauge cores. Prior studies reference using 6 to 8 cores for distortions, but after the discussion with our multidisciplinary team, we felt that taking 12 cores would provide adequate sampling for the distortion so that if we got a benign result, we all would be comfortable with the result.
And the article nicely compares with earlier literature using other biopsy strategies. So you mentioned patients potentially returning immediately to screening and not even undergoing the year of diagnostic follow-up. Any thoughts to share on this part of the article?
So our data does show that we had a 0% malignancy rate for the benign and radial scar distortions without a sonographic correlate. And that suggests that potentially these etiologies may return to annual screen mammography after biopsy. However, we haven't implemented this change yet at our institution, but the findings in our study will prompt a further discussion with our own multidisciplinary team in future meetings.
So it will be interesting to see what does come of that. You also talk about how the recommendations may depend on the type of atypia. Any further insights on this?
So our study found that for ADH, these were the only etiologies that underwent upgrade as surgical excision, whereas ALH and FEA did not. And so this aligns with the broader trend in breast imaging towards more selective surgical excision for certain types of atypia and potentially imaging follow-up for the other types. And so therefore, our findings essentially contribute to this body of literature supporting this evolving approach. And it'll be very interesting to see in the next coming years how the management for atypias will differ from traditional methods.
It sounds like that could be a good basis of maybe some future studies. So last question, are there any additional management changes that your group is considering now for distortion?
Yeah, great question. So this study focused specifically on architectural distortions without a sonographic correlate. And currently at our practice, for every distortion with a sonographic correlate, regardless of the biopsy result, we will refer them to the surgeon to discuss surgical excision. And moving forward, we may consider actually looking at these cases specifically to determine if distortions with a sonographic correlate really do need to be referred to surgical excision. Our methodology is that because distortions with a sonographic correlate has a high likelihood of malignancy, we feel that sending them to a surgical excision may help to reduce the risk of upgrade. But currently now we don't have any data to support that. And so that's something that we may be considering in the future to look into.
Yeah, so it looks like the work still is not done in this area. So Dr. Nguyen, thanks so much again for joining us.
Thank you so much for having me.